ఉంటుంది. మనకేమంటే ఇట్లా వస్తే మొత్తం కవర్ అవుతున్నట్టు. అది కావాల్సి అది డిస్ప్లే పెట్టినప్పుడు కొంచెం అది చేసుకుంటాం. అలా మిక్సింగ్ చేసుకుంటున్నారు. అదే డిస్టర్బ్ ఎవరు చేయరు, మీకు ఎవరు డిస్టర్బ్ చేయరు.
Hello everyone. We apologize for the delay in starting the conference due to yesterday's going on yesterday. A very good morning, honorable speakers, guests and participants. I, Dr. Nikita Joshi, Joint Secretary Stpi, feel privileged to welcome you all on behalf of Stpi Central Council to 10th Conference and Continuing Education Program of Society of Toxicologic Pathology India on topic Navigating Adversity and Advancing Non-Clinical Safety Assessment for Innovative Therapeutics with Satellite Symposia of the International Academy for Toxicologic Pathology, IATP, and the Asian Union of Toxicologic Pathology, AUTP, at Bangalore. As many of you know, the scientific heritage of Bangalore is both rich and forward-looking, with foundation of prestigious Indian Institute of Science, IISc, in 1909, to city being headquarters of the Indian Space Research Organization, ISRO, the Raman Research Institute, Vice President Dr. Satish Panchal, General Secretary Dr. Prabhu Patel, Joint Secretary Dr. Nikita Joshi, that is myself. So please. Since many years, as Stpi, now comprising of more than 320 members, with mission to serve welfare of humans, animals and toxicology. Every 2 years, we come up with new emerging topics of our conferences like Toxicology Pathology of Dermal and Juvenile Devices in 2021, a virtual conference. Immuno-oncology Therapeutics and Toxicologic Pathology of Special Cells of Toxicologic Pathology AUTP, a presenting education program in applicable.
I extend very warm welcome to every one of you gathered here. I extend very warm welcome to every one of you gathered here at the beautiful venue in Bangalore. We are delighted to see such a wonderful mix of scientists, toxicologists, toxicologic pathologists, pharmacologists, regulatory professionals, students and industry colleagues, all in animal health to the discipline of toxicology pathology. At the outset, I would like to acknowledge and warmly welcome distinguished dignitaries on the dais, a visionary leader whose commitment has taken Stpi to new heights. Our chief guest, Dr. S.G. Ramachandra, Chief Research Scientist at Indian Institute of Science, Bangalore, and a stalwart in laboratory animal science, whose pioneering work has shaped regulatory and ethical standards for biomedical research in India. Our General Secretary, Dr. Praful Patel, a dynamic organizer and driving force behind many successful STPI events. I also warmly welcome Dr. Venkatesh, Senior Vice President and Head of Toxicology at Landmark Pharmaceuticals. And also I welcome Dr. S. Vijayasati has been. Welcome to Dr. Nikit, participants who have worked tirelessly to make this India 2025, and thank you.
In March 2025, we held a one-day workshop in Pune, which many of you attended, either physically or virtually. International audience. Expertise in toxicology pathology in the country is carried out independently through our Indian Board of Toxicology Pathology, IBTP. First and 22nd workshops of IBTP. As of date, we have 68 IBTP diplomats in the country. On the international front, we strengthened our links with and that a new AUTP award and recognition for young scientists has also been. So this is a sign of the global stage. Thoughtfully curated our chosen themes, and we will push us move beyond and add discipline in the future. Of the dedication and teamwork of our Central Council, and by the support of all the sponsors who have generously come ahead and contributed for this cause. A big thanks to them. I would like to especially thank Vice President Dr. Satish Panchal, General Secretary Dr. Praful Patel, Joint Secretary Dr. Nikita Bhatt, Treasurer Dr. Sanjay Pan, Central Council. And a very special and heartfelt acknowledgement goes to Dr. Venkatesh Avrupa, our past President and advisor. Mention one person by name for exceptional dedication. It is Dr. Sanjay Paneria, who has worked tirelessly to navigate the financial, administrative and compliance matters for the society. Sanjay, thank you. As my term as President draws to a close, I want to leave just one message. Let us stay connected. Let us keep learning. Let us support our younger colleagues. Let us expand our role in the national and international conversation on safety science. There is enormous potential within this community, and the world of therapeutics needs exactly the kind of rigor, insight and balanced judgment that toxicologic pathologists are known for. Let STPI continue to grow as a central and authoritative platform for toxicologic pathology in India. Thank you once again for being here. Thank you for your support, your friendship and your commitment to the science. We all care so conference. Thank you.
Thank you, Dr. Deshmukh. Today, we have Dr. S.G. Ramachandra as our chief guest. Although he doesn't need any introduction, Before inviting him for inauguration address, I would say a few words in his introduction. Dr. Ramchandra graduated from Bangalore Veterinary College in 1987 and subsequently completed a post-graduation and PhD in veterinary pharmacology and toxicology from Bangalore Veterinary College. He has been working in field of laboratory animal science for the last 35 years and has been working as Chief Research Scientist at the Central Animal Facility, Indian Institute of Science, Bangalore. Served as the first Director of ICMR, National Animal Resource Facility for Biomedical Research at Hyderabad and established a state-of-art institute for preclinical animal experimentation under one roof for basic, applied, small and large animals from mice to horses are bred and used for biomedical research. He has undergone several advanced trainings in the laboratory animal medicine in USA, Germany, Taiwan and Japan. He served as an ad hoc specialist for the Association for Assessment and Accreditation of Laboratory Animal Care International, ALAP International, USA from 2009 to 2018 and serving as GLP Inspector for the National GLP Compliance Monitoring Authority, Department of Science and Technology, Government of India since 2010. He is associated with various regulatory authorities such as CCSEA, Ministry of Animal Husbandry and Dairying, Government of India, RCGM, Department of Science and Technology, Government of India, and GCMA, DST, Government of India, as a laboratory animal expert and also as task force committee member in Department of Biotechnology, Government of India. He is also serving as an expert in laboratory animals. He has organized several national and international conferences and workshops on laboratory animal science. Founder President for 9 years, 2004 to 2013. Also served as a council member of Asian Federation of Laboratory Animal Science Association of AFLAS Japan 2012 to 2014. He also initiated the Journal of Laboratory Animal Science and Indian College of Laboratory Animal Medicine and has been serving as registrar since 2021. He has been nominated and bestowed with the Nakula Award by the Karnataka Veterinary Association for his significant contribution to laboratory animals in laboratory animals. He has 6 patents in his credit. He has published over 100 research papers in peer-reviewed national and international journals. Thailand, South Korea, China, Sri Lanka, South Africa, Taiwan and UK. With this introduction, I invite our chief guest, Dr. S.G. Ramchandra, for inauguration address. I request Dr. Deshmukh to welcome Dr. Ramchandra with flower bouquet.
Nice introduction. Good morning to all of you. First of all, I would like to thank the organizing committee for inviting me to address this August gathering. It's my privilege to be here among stalwarts of pathology field. And it's again it's a pathology which most of you are involved here are involved in regulatory studies. Hence, I would like to share my experiences with regulatory activities today. So I have been involved in the regulatory activities for the last 2 decades, and also I am part of the phase 1 clinical trial with ICMR, so which has given me more experience or more understanding how the data what we generated in preclinical studies will get translated into human trials. So how they perceive the data what you generated, so is actually it's totally a different ball game altogether. So which I am going to share with you today. So India actually has seen a tremendous growth in preclinical research in the last 3 decades, especially after the liberalization. It's a huge thing, and it's all because of the good infrastructure what we have, and skilled manpower what we have, and also what you say that this is one of the greatest advantage in India what we have actually. So currently 60 GLP certified facilities are there in India and supporting more than 50 countries in the world in assessing their molecules for safety and efficacy. The study person, I think I'm interacting with many of you here when I go for auditing. So it's on the entire regulatory aspects also. So how to write the report and other things. And I have gone through the program list and saw that a lot of experts are program list and saw that a lot of experts are giving the lectures here with them, and then you gain what maximum knowledge out of them. So I wish all the success for this conference, and also happy.
Thank you, Dr. Ramchandra. I request Dr. Satish Panchal to present a memento to Dr. Ramchandra on behalf of Stpi. Inauguration function is nearing to end. I invite General Secretary Dr. Praful Patel for a vote of thanks.
Good morning, everyone. On behalf of Society of Toxicological Pathology India, it is my privilege to deliver the vote of thanks on this special occasion marking the inauguration of the 10th conference and continuing education program of Stpi being held in the city of Bangalore. For gracing the occasion with your presence and for your inspiring your words have truly set the tone for this conference and will guide us in our discussions over the next 3 days. A special thanks to all our invited speakers who have traveled from the various parts of India and abroad by their own expenses to share the expertise, insights for these 3 entire days. Your contributions are invaluable in advancing the field of the toxicology pathology and enhancing the knowledge to all our members and the participants. We also extend our sincere appreciation to all our sponsors and industry partners for their generous support. Your encouragements and collaborations make it possible to organize these events of this scale and quality. To all participants representing the India, academia, industry, regulatory bodies, thanks to all your enthusiasm and continued engagement with the Stpi. Your active participation is what makes this conference truly meaningful. A word of gratitude to all organizing committee, scientific committee, volunteers and every details. With this acknowledgement, it gives my pleasure to formally declare the conference open for the next 3 days. The 3 days of learning, sharing, networking and advancing the science of the toxicology pathology together. Thank you once again to everyone being the part of this milestone event. Let us forward to enriching the successful conference ahead. Thank you.
Thank you, Dr. Praful Patel. Thank you, everyone. I once again welcome you all on behalf of Stpi and wish you all the best for fruitful discussions and exchange of ideas for coming 3 days. This concludes the inauguration of the conference. We will begin sessions in 10 minutes. Thank you, everyone.
ಯಾರಿಲ್ಲ ನೀವು ಯಾರೋ ನಿಮಗೆ ಗೊತ್ತಿರೋರು ಬಿಡಿ ಸರ್
Hello. We are starting the session.
So we hear about adverse events in a clinical study. An adverse event is not necessarily related to a test item. It's just an untoward medical occurrence that you didn't expect when treating in a clinical study with a medicinal product, but it is not necessarily connected to the test item. We also hear about serious adverse event, which is a step further, or a congenital anomaly, a persistent or significant disability, and then also something which requires intervention to prevent a permanent impairment or damage. And finally, there is also the adverse drug reaction. This is an unintended change which is suspected to be due to a drug, but still there is no proven link to it. So it's important to note here that adverse in the clinical setting has a different meaning from what we understand by adverse in a non-clinical study. Now let's return to the non-clinical setting. As I said, there were simultaneous initiatives that started around 2013, 2014. There was the ESDP initiative, resulting in a publication with the title Characterizing Adversity of Pathology Findings in Non-Clinical Toxicity Studies, and representing the outcome of an ESDP International Expert Workshop. Then there was the STP initiative, also resulting in a publication with the title Recommended Best Practices for Determining, Communicating, and Using Adverse Effect Data from Non-Clinical Studies. And as I said, the STP-AS-CDP initiative, concentrating then on how can this be used in the setting of toxicological clinical pathology, and my colleague Lindsay will talk more in detail about what is relevant for clinical pathology. So the ESDP International Expert Workshop took care to involve a large number of international experts. So we were more than 20 of those, representing industry, pharmaceutical industry, but also agrochemical industry from various countries, various continents, and then also some persons from regulatory agencies. We prepared a face-to-face event via 6 preparatory teleconferences and presented to each other case examples in order to narrow down our understanding of what adversity can be. We developed a setting for a face-to-face workshop in Paris during 1.5 days, to which we also allowed an audience of more than 40 scientists who were able to participate in Q&A sessions in the discussions held by the experts. And our main aim and achievement was to come up with a working definition of adversity, but then also to develop a stepwise approach, how to come to a point where we can interpret or where we can set an adversity statement. I put this in parentheses, we considered what is specific about toxicological clinical pathology, but as said, this will be presented by Lindsay Tomlinson. And finally, our publication was endorsed by the major regional and also international professional societies of toxicological pathology. So it was really accepted, I would say, by the global community of tox staff. So the working definition. That's a little bit dry, and we had a lot of difficulties in elaborating this because there were a couple of mentions and a couple of interpretations of adversity already out there in the literature. So we tried to come up with something stating that adversity should be determined in the context of a given non-clinical tox study, that it is a test item related change that can be in the morphology or physiology or growth, development or reproduction of an animal model. So that is important. We are talking about the animal model in a given study. So it's not an extrapolation to humans, it is really the test, the animal model. And then such a change that likely results either in an impairment of the functional capacity to maintain homeostasis or in an impairment of the capacity to respond to an additional challenge. So important, first the animal model in the study, then also the likelihood, so we acknowledge that we cannot be 100% sure in many cases, but that we assess the likelihood. And then last but not least, it is not only something which is an impairment of the function that we can immediately see, but also something where we expect that the response to an additional challenge is disturbed. Some basic considerations of this workshop were: where should we report on adversity? So we said it is not always possible to do so in the sub-reports. It's not always possible or appropriate to do it in the toxicologic pathology report, but at a minimum it should be done in the study report. We also said it's not useful to do it in very early in exploratory or screening studies, but this might be a decision that is taken company by company. At which level of the organism should adversity be considered? We stated that it is not always at the animal level that such an adversity decision is made. It can be on the molecule, cell, tissue, or organism level. And we stated then that in standard studies it is usually done at the level of the cell, the tissue, or the organ level. By these statements you can already see that our discussions were not easy, so there were really several opinions here, and we were not able to agree on a level at which the adversity statement should be made. And what we also said is that there would be a need to better integrate the morphology that we see and then the understanding of molecular events leading to damage at any level, to help us to make adversity statements. Now, what I find very important, and which is also in preparation to the subsequent presentations, is that we develop a stepwise approach to determine adversity, because it's really very important to do it stepwise. First of all, make up the decision, is an effect treatment related, then is it test item related, and only then state on adversity. It doesn't make any sense to make an adversity statement on a finding that is not clearly test item related. And the last step then, after the adversity decision, would be how can I characterize it further? So there are some characteristics which we would add to the discussion of the adverse effect, but which are not determinants of something being adverse. And this is important. The principles of this stepwise approach are not specific to toxicologic pathology. Of course, they would apply also to in-life findings, to clinical pathology, and to other parameters assessed in the study. So let's show the different steps. The first step, as is shown here, is to ask yourself whether an effect is test item, is treatment related. Your concurrent control group, and by knowing your historical control data, it is important to understand whether an effect is incidental or vehicle related, or if it is a treatment related effect. And in a second step, knowing your experimental setting, the procedures, knowledge of your test item, and assessing dose relationship can be helpful to then determine whether something is a procedure-related effect or whether it is really test item related. And this is then the starting point to ask yourself if an effect is adverse or not. And I would like to state for the first two steps that it's really very important to know your historical control data. That was also mentioned in the inaugural speech. So it is important to know your background, because only then can you decide if a lesion that can also spontaneously occur in laboratory animals and in the species and strain you're using is exceeding what you see in the historical controls, and therefore can be also considered test item related. And it's important to make the right use of the historical control data, so really use historical control data from recent studies conducted under the same conditions. So in the optimum case, studies run in the same laboratory, with the same strain, with the same age, with the same sex of the animals, and really recent studies, usually not older than 5 years old. I also put here some factors that can help you to decide whether or not an effect is really test item related. In fact, there are factors which help you to exclude or to discard test item relationship if there is no obvious dose response, if you see that it is due to outlier, if the measurement of the endpoint is imprecise, if you see that it is within normal biological variation, and if you see that there is no biological plausibility. So these are factors that help you to decide that an effect is not test item related. So we have now seen the first two steps with the end result of having decided that an effect is test item related. Now comes step 3, to decide whether an effect is adverse. A test item related effect is adverse or not. And there are various factors that help here to have a look at the severity of an effect, the pathological nature of an effect, and the constellation of this effect together with other results of the study. And then we want to see if there is an impaired functional capacity to maintain homeostasis, or an impaired capacity to respond to an additional challenge, and this at the cell, tissue, organ, or organism level. So the pathological nature of an effect. We recognize that there are some lesions that we consider inherently adverse, like, for example, lesions in tissues where we know that the cells do not replicate, typically the nervous tissue. Then we also look if we have clear evidence of the impairment of a function or of the reserve capacity. That would help us. We look at the lesion severity, recognizing that there is a threshold for most findings between what we would think does not impair the function and lesions more severe that do impair the function. And because of this, we said that we need a precise grading of lesions so that we have an argument, we have a justification to say that a lesion was really severe. And the third parameter is here the effect constellation. So a particular lesion may be non-adverse when we look at it in isolation, but looking at it together with other parameters, we may consider it adverse. Like, for example, a liver change, not only with an enzyme induction and with a liver hypertrophy, but then also with evidence of necrosis. So these three together would then be considered adverse. So now we came to the decision that an effect is adverse, step 3. And what follows is step 4. As I said before, we can now characterize further the adverse effect. And we thought about 7 various characteristics that we could use to further describe the adverse effect, which would be an exacerbation of a spontaneous change, or is it a direct or indirect effect? Or is it an adaptive response? Is the effect reversible or not? What would happen if the animal is exposed for a longer time or at higher dosages? Is it translatable to humans? And is it based on exaggerated pharmacology, or what is the mode of action? The characteristics would be, for example, exacerbation of background finding. So we could state here about an adverse effect being a spontaneous lesion but occurring at a higher incidence or higher degree of severity. We would use the concurrent control group for comparison, and we clearly need here also a good knowledge about our historical controls, which we could use as a reference. Then we could discuss of the effect being direct or indirect. Not always the distinction is easy. It was important to say that also indirect effects, taken as such, can be adverse. I think it's the wind which is moving my slides. And finally, indirect mechanisms, as we said, do not preclude an effect of being called adverse. Like, for example, we can have a direct effect of an article on the heart, on tachycardia, which then leads to local myocardial hypoxia. And finally, what we see is a papillary necrosis, so it is only the end result of a sequence of events, but still the papillary necrosis would be called an adverse effect. We also discussed an adverse effect that can be an adaptive response. So we should describe that it is an adaptive nature of an effect, but depending on its severity, it can be considered adverse or not. And there is also the aspect of reversibility. So an effect that is reversible is not always non-adverse, it can be adverse. And the non-reversibility, of course, would be an additional factor helping us to decide on its adversity. And there are the aspects of extrapolation of longer exposure. I think it's a natural reflex when you see a finding to think, oh, this will become worse when I treat the animal longer. But this should not be done, so we should really assess adversity in that given study. And then, of course, we could discuss what we think might happen under longer treatment or with higher dosages, or it will be taken into account by toxicologists when designing the subsequent studies. Translatability to humans, yes, it's important, but it's not determining adversity, so it should be explained after the adversity call. And as I said, the pharmacological mode of action is also taken into account. And we recognize that for certain medicines, a certain threshold might be acceptable. So let's wait and see what the other presenters will say about their areas they will present. So now we talked about the 7 characteristics of adversity that were discussed and presented at the ESDP workshop. The main achievements of the ESDP workshop, I hope I have presented here, are that we had a working definition, that we clearly stated it must be assessed on a case-by-case basis, study by study, that histopathology only is not always sufficient, so we need additional information, in addition to the histopathology we see under the microscope. And that we came up with a very clarified structure of the process of how to determine adversity. So that should be helpful and is also a good help for younger toxicological pathologies. But it must be said that at the end we clearly recognize that there is no golden formula how to come to an adversity decision. So to a large extent it really depends on the individual assessment and expertise by the scientist reading the study and the exchange he or she has with the other scientists working on that study. I'm not going to read through this study, through this slide. It is the Stpi initiative, as I said, that was run almost in parallel to the ESDP initiative, and that was, to my understanding, more centered on the how do I present adversity. So there are 10 recommendations here, all of them really confirming or at least not contradictory, but rather complementary of what was done in the ESP initiative. So here also it was said, stay within a given study, statement on adversity in the sub-report and or in the study report, stay with your test species, assess a change on its own merit and do not extrapolate to anything else, use other study information to make your adversity assessment. And then the last statement is really very important. All available data from non-clinical studies must be evaluated together in order to predict human risk. So and now I will come to 3 case examples. As I said, my case examples are anonymized. I have adapted them and simplified them. And they are very simple, so please only take them as a teaser for the subsequent presentations. I will give you a very brief introduction to the study design, the main findings. I will present the histopathology instance table of the target organ, give you a couple of images, not many, just a couple. Then I will ask you for a vote, and I will give you some arguments in favor of the decision that finally was made here. The first example is about cardiac lesions. Cardiac lesions? Oops. Cardiac lesions in the dog. This was a 2-week study in legal dogs with a pharmaceutical, only 2 dose groups, no control group. The high dose was terminated early on day 5 because there were prominent clinical signs indicative of polyarthritis. Clinical pathology findings were seen in the high dose group only, reflective of a systemic inflammatory response. And there were a number of test item related histopathological findings that I do not present here, so I concentrate on the heart. But there were also joint findings, lymph node findings, liver and bone marrow findings. So here you can see the incidence table. In fact, there were only two dogs, 2 male and 2 female dogs in each dose group. And there were a couple of findings rated up to moderate in the high dose group. Important to see, I'm trying to use the arrow, which is very weak. Important to see here in one dog a moderate inflammation at the atrioventricular valve. In 2 female dogs, this was seen at a minimal degree. In the same male high dose dog, there was also a necrosis of the myocardium, the papillary muscle. And in 1 female high dose dog, an inflammation of the epicardium. And there was no finding at all in the low dose group. So here you can see the male high dose group, the male high dose dog with findings at the base of the atrioventricular valve. An inflammation that you can see here, it was mainly mononuclear cell. Here is a higher magnification. Here you can see also some mixed cell infiltrate. Over here. In that same male high dose animal, there was inflammation, and here you can see even some myocardial calcification in the papillary muscle. And this is a female high dose group where there is a very low grade and minimal grade of mononuclear infiltrate at the base of the atrioventricular valve. Now, the question might be, is this finding adverse at the high dose, or is it adverse at any dose? And if you like, you could raise your hand if you find it's adverse at the high dose. Okay. I see no hands. Thank you. Who thinks it's not adverse at any dose? I don't see any hand. Now the resolution is, we said it's adverse at the high dose because very likely there is a functional impairment of the cardiac log. In this early study, we did not have any in-life parameters to assess tachycardia or anything, so we did not have really other parameters indicating the impairment, but it's highly likely. Arguments against adversity, I tried to find some would be possibly, so if not following the step-by-step approach that I presented to you, that it's only secondary to a general inflammation, because there were also these inflammatory joint lesions, and that it occurred at a low incidence in only one high-dose animal in a moderate degree. So a very easy example, I would say. The next example is also from a beagle dog study, a 13-week study in beagle dogs with a recovery phase, where we had hepatocellular hypertrophy and inclusions. This was also a pharmaceutical, this time with a 3-dose group and 1 control group. And we observed a minor decrease in food consumption and in body weight that was fully reversible. There were minimally to mildly higher liver enzymes at the mid-dose and high dose, reversible. And then there were slightly higher liver weights in the males only, starting already at the low dose and reaching approximately 1.5x compared to the control animals when looking in the high dose. So on the right side you see a control liver from that study. On the left-hand side you see the incidence table of the liver findings, where we had findings in the mid and high dose group. So there was a hypertrophy, which we already noted in one mid-dose animal, and that was then a little bit more pronounced in the high-dose animals. We had cytoplasmic inclusions that we only saw in the high-dose animals, and then we had a rarefaction of the hepatocytes, which we saw in the mid-dose and high-dose animals, and even in one low-dose female. So here you can appreciate the hypertrophy in one female high-dose animal. I think for you it might be difficult at this magnification to see the inclusions, but at this magnification it should be possible, because it was really very impressive conclusions, where already like microscopically you had the impression that this was several layers of lamellar structures, and then also the rarefaction. We did electron microscopy, as you can see here, very nicely dense structures. And our question would be here, is this adverse at the high dose only, or at the high and mid dose, or not adverse at any dose? Just to make you think, is it difficult to determine at which dose level it's adverse or not? So who thinks it's adverse at the high dose level only? One person. Adverse at the high and mid dose? A couple of more persons. And not adverse at any dose? Also some. So that's more interesting now. And in fact, our conclusion was test item related, but not adverse at any of the dose levels. So here are some arguments that might point in the one or other direction. Why could it be adverse? Because we could ask ourselves, is there an impaired capacity of the hepatocytes to respond to an additional challenge if they have these large inclusions? We said, we saw in electron microscopy that it is an accumulation of ER and also an accumulation in lysosomal structures, so there might be an impairment. And also maybe some precaution, because we didn't understand the mechanism in this study. We didn't conduct further investigations there. But in favor of this change being non-adverse, there was only a minor effect on hepatic enzymes, so no further indication on impaired liver function, no evidence of death of hepatocytes, and an almost complete recovery. So we decided non-adverse, but as we can see here, and when only presenting it so briefly, might be difficult, and some individual might think in the one or other direction. And then the last example is also from a dog study, again a short study, a 2-week study with a pharmaceutical. Here we had 2 dose group and a concurrent control, and we had very impressive in-life observations already, shivering, trembling in the high dose group, and also in one mid-dose animal. Those findings were reversible, and we had effects on the food consumption and on the body weight in the high dose group, also reversible. Clinical pathology findings in the high dose reflected an acute inflammatory response. And histopathologically, we had test-isolated changes in the eye, at the retina, and in the brain in the mid and high dose, not reversible. So what did we have? We had in the brain, so I'm only presenting the brain here, perivascular infiltrates in the mid and high dose, but we also had very minimal and focal perivascular infiltrates in one control female. We had mononuclear inflammation of the brain parenchyma only in the high dose group, but up to moderate, and demyelination also in each one high dose, male and female. So here the question is about which dose group might show an adverse effect. Let me show the pictures. So here we see a mid-dose animal with a minimal perivascular infiltrate. Here we see a high-dose animal with a mild perivascular infiltrate and also a minimal infiltrate of the parenchyma here. And this is a high-dose male with a widespread infiltrate and also demyelination that we can see here in the brain parenchyma, and then also perivascular infiltrates spreading into the parenchyma. And again, at the higher magnification, this really prominent effect. And even in a recovery dog, we still saw small infiltrates in the parenchyma together with one perivascular infiltrate. Our question here is adverse only at the high dose or adverse at the high and low dose? What do you think? So who thinks it's adverse at the high dose only? Yeah, I see a couple of hands. And who thinks it's adverse at both dose groups? More hands. And this is what we thought. We said we consider it adverse at both dose levels. On the right-hand side, our arguments in favor of this. First of all, because it is the brain. Then, because there was evidence by these perivascular infiltrates that the blood-brain barrier was crossed. We had infiltrates around the vessels, but also in the parenchyma. And then, because of the clinical science, we also had in one mid-dose animal. One might argue it's not adverse at the low dose, because the brain parenchyma itself was not involved at the low dose, and there was no clinical pathology findings indicative of an inflammation at the low dose. So again, a weight of evidence approach, which might lead to a different interpretation by the one or other pathologist. Our overall conclusion of this was, of the ESDP workshop, together with the other material I presented to you, the assessment of adversity is needed. There were initiatives within the tox staff community that should help to clarify the process. Please bear in mind the constellation. Do not only concentrate on one finding, but see the overall results of the study together. Please do a step-by-step approach, so don't feel tempted to call a finding adverse, even if you're not sure if it's not procedure-related or just a chance event that will be misleading. And then it's very important to state that there is no one formula that leads to a good adversity assessment. It's really, I would say it's an art. And then last but not least, and I underlined it in green, I really find it important that that is my experience. There will be differences between companies. It's very important for a company to have a philosophy on how to come to an adversity decision. So a line between the scientists within a given company. That is really very important. So I would like to thank the various societies that have conducted these initiatives that were really very important. I would also like to thank the scientists that have participated in the initiatives, but also that have offered the case examples. And last but not least, I would like to ask again the Indian Society for this great event. Thank you very much for your attention. And I'm not sure if there is some time for questions left.
Yeah, thank you very much, Amy, for the wonderful presentation. And we have a time for taking one question because we already have a panel discussion scheduled towards the end of the day. So we can have one question and then we'll jump to the next one.
Thanks so much for a wonderful talk, Gabby. That's too close. Can you hear me? Yeah, so my one question is, you mentioned the importance of historical controls, and I was just curious if you've thought about all of the work that's being done with virtual controls and how that will play into our determination of adversity in the future.
Thank you, Lindsay. Well, in fact, I think virtual controls is a great idea, but it's very, very difficult to put in place. So I'm talking from my current standpoint. I'm sure it may evolve because time and technology is evolving so fast, but from the day of today, I have really great difficulties in imagining how virtual controls can be put into place unless you have a huge test facility with a lot of parallel studies run at the same time with exactly the same design, which allows you to choose from this large panel of studies your virtual controls that you reuse in future studies. If you have a smaller test facility and your toxicologists, your project teams ask you to add only 2 new biomarkers to a new study, how are you going to conduct that with a virtual control group? So, to be honest, I don't see the limits that much in histopathology. I see them in clinical pathology and in other disciplines that really need more than the anatomic pathologists a concurrent control to make exact assessments. Thank you for the question.
Our next lecture is from Dr. Lindsay Tomlinson, and she's a DBM DBSc, graduated from Ontario Veterinary College, Ontario in 1995 and 1999. And Lindsay reached and defended her thesis on chlamydial disease in sheep in DBSc program and serves as in hand for female reproductive pathology. Lindsay has more than 23 years of experience in toxicology pathology and project experience between PMS and Pfizer. She has obtained board certification with the American College of Veterinary Pathologists in anatomical and clinical pathology and with American Board of Toxicologists, ABT, in toxicology. She has been active in her professional societies and has contributed in several key regulatory manuscripts. Highlights of service have included ACVP Awards and Focus Scientific Sessions Chair, SVP, CP, President of the Executive Board and Regulatory Affairs Committee. and STP Executive Committee member and Scientific and Regulatory Policy Committee chair. In recent years, Lindsay has been supporting development of mRNA vaccines, managing the evolution of digital pathology, including artificial intelligence in pathology in a toxicology setting, to assist pathologists and supporting efforts in the development and incorporation of complex in vitro models into the standard testing paradigm. So I request Lindsay to speak on this adversity topic.
Yeah, just give me a moment. I request all participants to keep their mobile on silent mode and avoid talking if it is not urgent, because it's all important presentations and speakers are traveled from all around the world, so let's utilize their presence and listen to their fabulous talk. Thank you.
Thank you so much for the introduction, and thank you so much for having me. This is a really wonderful opportunity, and I'd like to echo what Gabby said, that we've seen just a little window of India, and I've learned so much in this short period of time, and it's been really a wonderful experience. And so we're going to conquer the biomarkers of adversity now. So I also would like to say that these are my own opinions and not those of my company. And so we are going to start with how to address adversity in clinical pathology, how we got here, some considerations that you should consider when you're evaluating your data. Then we'll go over some take-home messages, and then I will share 2 ClinPath cases. And we'll do some voting along the way, similar to what Gabby did. And then if there's time, we'll have a few questions, or we can have them in the panel session later. And I just want to say that this image is you at the top of this mountain, because you're going to conquer ClinPath and the biomarkers of adversity. So let's go. So as Gabby mentioned, there was the foundation that was built by STP and ESTP. And then in clinical pathology, the clinical pathologists that I've worked with wanted to elaborate on some of those concepts that were originally explored at the ESTP workshop. And so the Regulatory Affairs Committee of ASDCP, which is now called RETAC, or Regulatory Industrial and Toxicologic Affairs Committee, which you may know them as now, expanded those concepts that were originally addressed in the papers that Gabby mentioned. So during that process, there was input from the whole ASDCP membership, the Clinical Pathology Interest Group, or CPIG, of STP, and that resulted in a manuscript that was published in 2017. And this is the manuscript, and I think it is still very relevant today, and these concepts can still help you at this point. I have to actually peek over, so I'm going to do a little bit of light exercises just to give you this talk. So one of the things that we found out is that there's very little regulatory guidance on adversity for clinical pathology. And one of the things that we found was that the World Health Organization had a core assessment group on pesticide residues in 2015. And the recommendation that they came up with was that if there's an increase in blood methemoglobin of greater than 5% in dogs and more than 1.5% in rats, then that should be considered adverse. I don't know about you, but I have never evaluated methemoglobin in one of my studies. Has anyone in the audience? So one person, a few people have, so that's great. You have a specific recommendation for that measure. But I think for most of our standard studies, we don't measure that, and so that hasn't been super helpful. The definition that the Regulatory Affairs Committee landed on was to support that of Palazzi et al. That Gabby described, that was put together by the ESTP workshop. And I think it's also important to be aware on the clinical pathology front that in the NCI common terminology for humans, that the criteria for adverse events is very different. And so I pulled out the clinical pathology endpoints that adverse grading has been identified for, and supporting what Gabby said, that it's very different than how we evaluate non-clinical studies. However, it's important to be aware of, and so it's a good reference so that you understand that translational piece and what clinicians are going to be considering, and how regulators might also think about your endpoints. So now we're going to go through these 4 considerations for adversity calls. The first is that, and then we'll dig deeper into each one of them. So the pathogenesis of the change is very important. So the same finding can be either adverse or non-adverse depending on how the change evolved. Rapidly changing values and persistent changes can impact the adversity call. So the same finding that occurs very rapidly or occurs slowly, it can have a different result. The third is that clinical pathology changes in the context of adverse anatomic pathology findings or specific adverse clinical outcomes should be considered adverse in light of the entire set of data. Or that's the part of the constellation of adversity that Gabby described. And then fourth, not all reported endpoints require an adversity call. And an example just here as a high level is that calculated endpoints, such as the AG ratio, don't require an adversity call. But we'll go through a few more as we go. So starting with the pathogenesis, as I mentioned, and this is where I'm going to put you to work, so stay on your toes. Both adverse and non-adverse processes can result in a similar degree of change. So if you take increased BUN, serum BUN, and creatinine as an example, if it's due to dehydration accompanied by low urine volume and high specific gravity, put up your hand if you think it's adverse. Okay, no hands. And you're right, it's non-adverse in most cases. Next example, if increased BUN and creatinine is associated with anuria, oliguria, and or polyuria with low specific gravity, so you're not able to concentrate urine, and you have microscopic evidence of kidney injury, would you consider it adverse with a show of hands? Okay, a lot of hands went up. And yes, that's adverse because it's indicating that there's altered kidney function. Okay, this group is on their toes, awake, had lots of coffee, and is ready to go. So the next one is hypoalbuminemia, or low serum albumin. So if there is decreased albumin associated with an expanded plasma volume, put up your hand if you think that's adverse. No hands. You guys are excellent. So it's non-adverse in most cases. And what about if there is the low serum albumin is due to protein loss, and that low albumin is resulting in edema? What do you think? Put up your hand if you think it's adverse. Okay, excellent. It is adverse, as we know, albumin is a key contributor to oncotic pressure and maintaining that fluid in the vasculature. Okay, on to rapidly changing values and persistence. So the same degree of change could be adverse or non-adverse, depending on how quickly that change happened. So when the red blood cell mass drops rapidly due to bleeding, there is more likely tissue hypoxia going to happen. But if that happens more slowly over time, then you're able to accommodate for that. And if it happens really quickly, then you'll have associated clinical signs of weakness, fainting, and even death, which of course is supporting evidence of adversity. As another example, a rapid onset of hypoglycemia can result in seizures, coma, and also death, which is obviously adverse. But when it's slower with onset, then the body can adjust and you can change energy sources and the same level will not be adverse. So next, transient changes are less likely to have adverse consequences than persistent ones. So if you have a change at one point in time, so say take neutropenia, the neutrophils are low at one point in time, below a critical level that we'll talk about, but they're back in the normal range at every other time point, and it's only a few animals, then it may not need to be considered adverse. So really understanding how quickly something comes on and how persistent it is, very important. You have to consider the entire data set. So I just wanted to share a few things that are interdependent and also drives that point home again that you have to think about the constellation of adversity. So if you are taking repeated blood draws, then you can affect the ability of hematopoiesis to normalize the red cell mass. And the timing of those blood draws and really thinking about the maximum amount that you should take from an animal is really critical. Another thing is that when you have dehydration, you have less plasma volume and so an elevated red blood cell mass. And so that can actually mask blood loss when you have both things going on at the same time. Also, an increased fluid volume, decreasing albumin, should have an associated red cell mass. So we talked about that and you understand that well. And low albumin due to liver failure would be associated with lower coagulation proteins. So in that case, you would also have findings associated like prolongation of PT and APTT. You could have low urea, you could have low glucose. And then that helps you to understand if that is due to liver failure or just an increased plasma volume. And so we now want to talk about some of the parameters that have critical values so that while it's rare that you'll call a clinical pathology finding adverse in isolation, it's possible. And now we'll talk about that. So when it comes to those critical levels, we'll talk about platelets, red blood cell mass, neutrophils, and albumin. And although I don't have critical values for the altered coagulation pathways, we all understand that it's walking a very thin line, so I thought it would be worth including it here in the discussion. So when platelets go below a threshold which allows spontaneous bleeding, that is considered adverse. I think we all agree to that. But if there is no bleeding associated, is it still adverse? So with a show of hands, if you don't see bleeding, but you see a critical value for platelets, is it still adverse? This is a tough question, but show me what you think. Is it adverse? Okay, it's not as clear, but a few hands were up. Oh, that is the voting, which you did. And I would advocate that it is still adverse. So, you know, we can talk about that later for those that didn't put up their hands, and we can understand each other's thoughts a little bit more. But I will say that we still want to see that reproducible and persistent marked decreases in platelets to call it adverse. So absolute values of less than 50,000 per microliter. I have some ranges here, reference ranges for different species for you to look at. But basically, if it's greater than or equal to a 70% decrease in dogs, 80% in non-human primates, or 90% in rats, from control or baseline, depending on what your comparator is, then we would consider that adverse. And then, of course, there's an even greater chance of bleeding if you have less than 10,000 per microliter. And I would say that if you have that, and it's persistent and reproducible, you should call it adverse. So moving on to low red cell mass and hypoxia. So again, you want to see a reproducible marked decrease in red cell mass. And I won't say the reference ranges again, but I'll say that if you have absolute values of less than or equal to 7 to 8 grams per deciliter, then that would be considered adverse. And that equates to greater than or equal to 35 to 40% of decrease in hemoglobin using hemoglobin from control or baseline values, depending on your reference point. And I will also say that lower severity of an acute drop, as we mentioned, would be adverse. And that at that level, clinical signs of weakness and tissue hypoxia are more likely to occur. And I provided some references there. Okay, so moving to neutrophils and get ready to vote. So similar theory, reproducible, persistent, marked decreases in neutrophils are going to be considered adverse, and those values less than or equal to 500 per microliter in the NHP in the non-human primate and dogs, and less than or equal to 50 per microliter in the rat should be considered adverse. And there is an increased likelihood of secondary infections, especially if the bone marrow is depleted. So, is the potential for infection sufficient to call adversity? So meaning, if you have these neutrophil values, but you don't see infection, are you still going to consider it adverse? Okay, raise your hands. I'm going to use my voting slide this time. Raise your hands if you think that you should still consider them adverse. Okay, small number of hands, and I would say that for those hands, fantastic. Yes, I agree that those should be considered adverse. I would say that lymphopenia is really difficult to come up with a critical value. And then also that because lymphopenia is part of the adaptive immune response, we don't think of it in quite the same way as neutrophils, because neutrophils are part of the innate immune response and that first line of defense. And so if we reach those critical values with neutrophils, then we should be really concerned. Okay, talking a little bit about albumin. So, severe acute hypoalbuminemia resulting in loss of oncotic pressure, as we've talked about, is adverse. And when there's no time to accommodate, you will end up with edema in the interstitium, and you'll even end up with third space losses like ascites. And there was a study in dogs where they did plasmapheresis, and they replaced what was removed with isotonic fluid. And when they drove the albumin down, even though they didn't even drive it below the reference range, they found that there was fluid moving into the extracellular space. And so even at low reference range values, you can have adverse albumin levels in edema. So that's where you have to really think about that constellation of adversity again. But the cautionary tale is that if it is going down more slowly, then the proteins in the interstitium actually decrease. And that changes that gradient, the oncotic gradient, and protects against edema. And so, again, having that information and putting all of the findings together is so important. So, I guess it goes without saying that marked or severe decreases in albumin associated with clinical edema are adverse, irrespective of how the albumin decreased. And so I want to just remind everybody of the coagulation pathway. I know we all know it, but it's always nice to have that refresher. And there are many pharmaceuticals that do affect the coagulation pathway. So we can think about hemophilia when we think about the yellow, the intrinsic pathway, and there are replacement therapies out there, and of course in normal animals that can result in clotting. And so again, understanding and finding that balance will be really important. And for the extrinsic pathway, with factor 7 and tissue factor, there are important proteins managing tissue factor. So the tissue factor protein inhibitor, TFPI. So TFPI is then anticoagulative. And then if you have an antibody for TFPI, then again it's procoagulative. And so you can see that you can actually get yourself confused. You have to really think through which piece you're affecting and which way it's going to go. And then I also wanted to just mention that common pathway, that there are factor 10 inhibitor on the market. And it's amazing that you can impact the common pathway and still have good, safe, efficacious drug delivery. So a little bit more on the coagulation pathway and bleeding. As Gabby mentioned, pharmacology, and when you push the pharmacology, that can be considered adverse. So excessive bleeding is not tolerated and can be life-threatening. So if that is on target pharmacology and you pushed it too far, that's adverse. And then you would have associated findings like prolongation of PT and APTT, and those are then part of the constellation of adversity, even though we wouldn't consider them adverse in isolation. The same coagulation time, so the same changes in PT and APTT can be also non-adverse. And one thing to really consider, and I think is fascinating, is that the kinetics of the pharmacology are critical. So not only are we looking at the endpoints and the associated anatomic pathology, but we need to also consider the toxicokinetics and the clinical signs that we're seeing in study. And so when the half-life is short, then you can have the same prolongation of PT, APTT, and it's not going to cause bleeding, which is wonderful, and that is how we can have effective medicines that have prolongation in PT and APTT for a short period of time. And so our fourth consideration is that not all endpoints require an adversity call. So isolated changes in red cell mass variables, such as mean cell volume, mean hemoglobin concentration, and mean cell hemoglobin concentration, you wouldn't consider them as adverse when you don't see a change in the overall red cell mass. As mentioned in the early slides, ratios don't warrant an adversity call. I will just mention that large unstained cells are not a cell type, and so if you do have a lot of large unstained cells, you need to understand what those actually are. So a leukemia would drive that data point, but would not, the important piece would be that the leukemia, and not the fact that there are large unstained cells, because it just tells you that there are either large lymphocytes or monocytes, and you have to think about more detail and not the LUC itself. And you also must consider the normal range. So for something like bilirubin, drops are not relevant because of the dynamic range. It can be very, very low. And so a drop in bilirubin should not even call test article related and should not call adverse. So as take-home messages, ClinTac changes are not just statistics. Before you assign adversity to a clinical pathology change, consider, is it consistent? Is it persistent? What other data does it correlate with? Can changes in clinical pathology explain the other findings on the study, the microscopic findings, the clinical observations? Look at the whole data set. You do not have to assign adversity to every change, but you do need to consider every change when determining the no-AEL, as Gabby mentioned as well. Okay, I think this group is ready for 2 cases. You are all very, very responsive and very, very accurate in your responses. So first, we're going to deal with some hormones. So this is a 6-month rat study. There are 15 per sex per group. It's a small molecule program with oral daily dosing. So due to a concern for effects on female reproduction, the additions of luteinizing hormone, follicle stimulating hormone, progesterone, and estradiol were added at weeks 2, 14, and 22. And so just so I don't want to be unfair, and we don't all look at hormone levels every day, so I'm giving you this preparatory slide for the rodent estrus cycle. And so, as you can see, there are increases in LH and FSH in the proestrus and estrus time points. And then you can also see how progesterone and estradiol change throughout the cycle. So just commit that to memory. Got it? Everyone got it? Yeah? So this was the result for the female reproductive hormones. So for LH, there was a change at week 2 at the high dose only. For FSH, and you can, the trick is look for the red numbers. Those are the test article related changes. So for FSH, there was an increase at the high dose at week 2 and 14, and that also was evident at the mid dose at week 14. But at week 22, there were no test article related changes. And then progesterone, similarly at the high dose, but all time points, and that went down to the mid dose at just week 22. Okay. So everybody's got in their head where the red numbers are, right? And then just to give you a little bit more visual, here are the graphs of LH and FSH, where you can see that there is separation of the high dose just at that week 2 time point. And you can also see that FSH is increased at both 50 and 500 at the mid and high doses in week 14. And I didn't mention estradiol. There were no test article related changes in estradiol. You can see that here. And you can also see that there were lower progesterone levels at weeks 2, 14, and 22 at the high dose, but also the mid dose in week 22. And after the recovery period, there were no test article related changes in these female reproductive hormones. Okay, so what we're going to vote on is, do you consider at any dose the changes in any of the reproductive hormones adverse? Raise your hand. 1. Anybody else? A few? Okay, there are a few. Okay. So I guess that the rest of you wanted more information, am I right? I think so, yeah. So what I'm going to say is that we want to look at the anatomic pathology findings. And so in the ovaries, there was an increased incidence of cystic ovarian follicles, and it was a slight incidence increase. And there was a reduced number of corpus lutea, and again, it was a shift, but there was still evidence of both things in the controls. So it was a shift, but there was a shift at all doses, and that reduced number of CLs correlated with the reduced progesterone levels. And so I will also add that the findings in the uterus, cervix, and vagina were consistent with those of the ovary and consistent with persistent estrus. and that was that in the endometrium of the uterus, there was tall columnar epithelium, and in the vagina, there was cornification of the mucosa. And so actually at all doses, it was hard to determine the cycle of, the stage of the estrous cycle. And you can see in this image, C and D, the lower two. The top two would be control. The lower two are cystic follicles. So let's vote again. Does anybody at any dose think that there was adversity in the hormones in relation to the anatomic pathology findings? With a show of hands. Okay, many more people. Okay. So I would say that it was still tough in this study to tell if those findings were adverse in isolation, but they were consistent with persistent estrus, so that is concern for a change in reproductive function. And so here is the clinical cycling information, which you really need to then also have. There was actually, early in the study, changes in the estrous cycle at the high dose. By week 14, there was a change at the high dose and mid dose, and by the end of the study, there were changes at all doses. And the only animals that were still cycling at the end of the study were the controls. So there was an alteration in the estrous cycle in all those groups. And so you are correct, there is adversity, and there's adversity in reproductive function at all doses. The relevance to people is another question. The hormone changes correlate with those alterations in the estrous cycle, and so are part of the constellation of adversity, but I wouldn't have called them adverse on their own without knowing the full picture. So you did great. We have one more case. Do we have time for it? Okay. I wasn't sure if the noise would, okay. Great. Okay. So this is a bone marrow challenge. I think you're up for it. And so we will look at some changes in hematology. This is a study with 24 males and females. They're Sprague dollies, and they started the study at 7 weeks old. It's a 2-week study. They're housed individually, and they were in one of 4 groups. They either got 100% or 22 grams a day of feed, or they had 75%, 50%, or 25%. And at the end of the 2 weeks, there were decreases in white blood cells, lymphocytes, monocytes, eosinophils, and basophils. There are also decreases in platelets and decreases in reticulocytes. There are also changes in red blood cells and neutrophils. Okay. So here are the changes. Hopefully you can see it. Maybe I'll point them out. So in the reticulocytes, there are changes in all groups, other than the control group, and similarly in females and males. The changes in platelets are less obvious at the 75% group and even the 50% group in males, but there are changes in the 25% group. White blood cells, similarly, 75% group is not so changed, but it's more prominent in the other two. Lymphocytes, similarly, definitely the 50 and 25% groups are affected in both males and females. And then there are also changes in eosinophils and monocytes. Okay. So it is a feed restriction study, as I mentioned. And so the effects of reduced food intake are well described. And we do expect that the findings are associated with nutritional deficiency, dehydration, accelerated protein catabolism, stress, and/or hemolysis. So that's a lot to sort of navigate, but I wanted to give you that teaser. And so now in voting, do you think that any of those clinical pathology changes were adverse in any of the groups other than the control group? So raise your hand if you think there were any adverse changes. Okay, few hands. Okay, but I guess that the rest of you want more information, am I right? I think so. Okay. So here are the anatomic pathology correlates. There are decreased lymphoid organ weights, spleen and thymus, and that is at the 50% and the 25% groups. There's also microscopic lymphoid depletion in thymus, spleen, and lymph nodes. Erythrophagocytosis was seen in the spleen, and there's also bone marrow depletion only at the 25% feed group, which is, I don't want to confuse them, 75% feed restriction. Okay. And here's the visual. So here are the test article-related organ weight changes in yellow at the 50 and 25% groups. And then you can see that at the 50% group that the changes go up to, of depletion, go up to moderate for both bone marrow and thymus for just females, and or less in males. And then you can see that there are up to marked changes in the bone marrow and thymus. Here, I will just make here marked changes bone marrow and thymus in both females and males for just the 25% feed group. Okay? And so here is the bone marrow cellularity microscopic evaluation. So the control female, you can see the top has the top image has good cellularity. And then you can see the 25% control diet, which is 75% feed restriction. There is marked depletion of the hematopoietic cells. It's hard to find hematopoietic cells actually in there, isn't it? Okay. So now, with a show of hands, is there adversity in any of the feed groups? So raise your hand if you think there is in any of the groups. Okay, more hands. Excellent. So these are expected findings with food restriction. However, when you restrict feed to the point that you wipe out that bone marrow, you should consider it as adverse. Not for the clinical pathology changes in isolation, but with all of the data together. And so this is actually one of the examples where you can have opposing influences on red cell mass, because with feed restriction you can get some hemolysis, you get that bone marrow damage, you can get secondary tubular necrosis in the kidney, but you have a counteracting increased red cell count with dehydration. So those things are playing off each other, which makes it actually difficult to see the increased red cell, to see the decreased red cell mass because of the increased red cell mass. You know where I'm going with that. There are also decreases in the circulating hematopoietic cells because of the bone marrow depletion. That reticulocytes, although we don't have a critical value for them, should be cautionary. If you see decreased reticulocytes, it may be too early to see a red blood cell change. And so it should be a flag in your head, like I need to know what's happening in the bone marrow if I can't explain those decreased reticulocytes. Also, we see decreased circulating lymphocytes and lymphoid depletion, which is exactly what we saw, and a lot of other endpoints occur, and they're related to metabolism, such as decreases in serum protein, cholesterol, triglycerides. Glucose can go up or down, and phosphorus, decreases in phosphorus. As well as decreased zymogen granules in the pancreas, and you can also see decreases in secretions in the salivary gland. So lots going on with feed restriction. We didn't cover all of it. But I did point to this in the discussion on reticulocytes. It is important also to know when to do a bone marrow smear evaluation. So a lot of the times we don't need to evaluate the bone marrow. So here are 4 major reasons to do it. When you have persistent or unexplained non-regenerative anemia, when you have unexplained neutropenia, when you have unexplained thrombocytopenia, and when you have abnormal cells in the bloodstream. So, should we do a bone marrow smear evaluation in this case? Can you show me if you would do one in your study? Okay, I would argue that in this case, we know what is happening. So we know that there's feed restriction. If animals go off feed in a study, you're going to know that. And if you see those secondary bone marrow findings, you'll understand what's going on. So I would argue that you might be able to save those resources and not do the bone marrow smear evaluation. So I think we've covered this, that really it's that 75% feed restriction where we have the bone marrow change. That's where we want to call it adverse. And we have all of those associated changes, but we wouldn't want to call the hematology changes adverse unless we understand that constellation and full data set. And with that, I want to thank you for being such an active and participatory audience. You've been excellent. And I also want to thank all of the colleagues that I worked with during the STP, ASCCP evaluations, and I also want to thank my new company, Alumni, for letting me come. So thank you very much.
Thank you, Nancy. It's wonderful, fantastic presentation. So over to the audience for one question, and then we'll break for coffee. Yes, one question.
Thanks, Lindsay. So the last, this case number 2 was quite interesting. I'm thinking about, I do a lot of research myself, and I don't feel non-adverse. Actually, anything I feel better whenever I go off food. So I think it depends, brings to the point which you say, it depends how quickly you're trying to drop. If I see a 1 kilo drop in 2 days, I think I should be worried, not over a month. Actually, that I would like to see that. Which brings to the point that while we are focusing on just clinical pathology and anatomical pathology, there is a sometimes study director in toxicology and show that in the audience, they go by percentage weight and call it worse. So let's say I don't see anything in pathology, nothing in histopathology. Sometimes you see thymic stress, but if there is more than 10%, 15%, there's always this argument. And I will argue, I don't know how much weight loss you saw in your 25% or 75%. Wouldn't you consider that also a factor, regardless of clinical pathology or histopathology?
Absolutely. Yeah, it wasn't fair that I didn't give the weights, absolutely. But yeah, I agree that we should look at the amount of weight loss as well. This was a 2-week study, and so I think that 75% feed restriction, there was over 10%, but not at the other lower levels of feed restriction. And so, yeah, I think that the amount of weight loss is absolutely important. And again, tying that into all of the other data would help all of us to make the case of which level is adverse.
Thank you.
I request Dr. Satish Panchal to give a token of appreciation. we'll break for a coffee tea break now till by 11:35. 20 minutes break.
Risk assessment, and in the EU you have risk assessment as well as a hazard assessment, and this is based on different regulations coming out in Europe in 2009. There is a regulation regarding the approval, marketing and use of plant protection products, and also regulation which regulates classification, labeling and packaging of certain substances. And these assessments operate with so-called cut-off criteria in Europe, and this has to be known that there might be cut-off criteria in the registration of agrochemicals. And for that there are given guidelines in the Annex 2 of the 1107 regulation from 2009, and there is also a guidance of the application of the so-called CLP classification, labeling and protection criteria, which were given by the EFSA, the European Food and Safety Agency, as well as the ECHA, the European Chemical Agency. So what is written there? So the European legislation tells about carcinogenicity in the Annex 2. It's differentiated in different chapters. In the chapter 2 there are general decision making, and in chapter 3 there are described the criteria for an approval of an active substance, and then again they are classified or given the criteria for the so-called cut-off criteria. The classification written carcinogenic, mutagenic or reprotoxic active ingredient which meets category 1A or 1B cannot be registered in Europe, as the same is also true for endocrine disruptors. And this is then also written down in these. Can you see? Yes, in this regulation. And what about the CLP regulation? In the CLP, in the classification regulation, there is given in detail the classification for carcinogenicity, and you have two different categories. The category 1 is differentiated in A and B, and the class 1A would be a known human carcinogen based mainly on human evidence, and then the category 1B, this is described as presumed human carcinogen based mainly on animal evidence, and category 2 would be a suspected human carcinogen. And the pesticide, active ingredients, the biocides, and also efficiency, and the respective labeling is mandatory. And you can see here these different categories, and what I already mentioned before. If you have an active ingredient classified as 1A or 1B regarding of carcinogenicity, mutagenicity or reproductive toxicity, there will be no approval for registration in Europe. Only in category 2 the approval might be possible, and the best thing would be that you have no classification at all. But you have to be aware that the classification in 1A and 1B would not be able to register a product in Europe. And then the point of departure for the so-called risk assessment, you have to identify adverse effects resulting from long-term exposure to the active substance. You have to identify target organs where it is relevant. You have to establish a dose-response relationship, and you have to establish an ORL and, if necessary,
other appropriate endpoints. And we heard about that already a lot from Gabi and also Lindsay, that it's really essential to identify your target organs, you set the NOAL, and you have any clue about diversity. And in addition, adverse defects relevant, which might be relevant for hazard assessment. So you have to identify carcinogenic effects from long-term exposure to the active substance. You have to establish the species, sex, and organ specificity of tumors which are used. You have to identify the maximum dose with no carcinogenic effect. So this means that you have to have NOAL for the carcinogenic potential. And this is extremely relevant, you have to determine the mode of action and the human relevance of any identified carcinogenic response. And this might be a little bit different from the pharmaceutical company. For registration of an active ingredient from plant protection products, you have to know the mode of action and you have to give an answer to the human relevance, otherwise a registration is not possible in Europe. And I think most of you know the guideline requirements for long-term and carcinogenicity studies, which should be submitted in Europe. So normally it's the OECD test guideline 453 and 451. The one is the combined and the other is the only the carcinogenic part. Good. Does not work. For the dose selection, it's really relevant that the highest dose should identify in principle target organ and also toxic effects, but the body weight gain, for example, should not should be higher than 10%. You should avoid suffering, severe toxicity, morbidity, or death. A lower dose may be chosen if, for example, a dose leaves an adverse effect of concern with little impact on lifespan or body weight. And the dose spacing, normally factors are used between 6 to 10, but you should avoid factors over 10. And at least you have 3 dose groups and also 1 concurrent control, and you will have 50 animals per sex and dose, at least for the carcinogenicity question. And further considerations which should be taken on the dose selection, if you have already a little bit knowledge about your mode of action, so the key aspects of mode of action, and also regarding kinetics, for example, the saturation or the non-linearity between external and internal doses. So what you should consider, and this is especially my personal opinion, if you have a certain finding, then it might be that you have already, before you submit your dossier to the regulatory agencies, you have to consider what might it be or what does it mean for your active ingredient. And first, if you have a tumor incidence with a likely genotoxic mode of action, then it will be the category 1 and registration will not be possible. If you have a tumor incidence with an unknown mode of action, again, this will be category 1 and there will be no registration possible in Europe. If you have an increased tumor incidence in 2 species, and or sex and also in several target organs with an unknown mode of action, this also means that you will be classified as a category 1 with no registration. If you have a tumor incidence increased with a known mode of action, then most likely it will be a category 2 and registration is still possible. And if you have a increased tumor incidence with a known mode of action and a clear evidence of non-human relevance, then you will receive no classification and a registration is possible. And that's the reason why the knowing of the mode of action and also the clear evidence of non-human relevance is highly important for the registration of plant protection products in Europe.
and further elements which are considered during the ECHA RAC discussion, and RAC means Risk Assessment Committee. So it's the frequency of any finding, the dose levels, do you have excessive toxicity, then again which organ is affected, the incidences, the statistical significance, the robustness of your shown mode of action and the non-human relevance analysis, and also the threshold. And at least when the tumor incidences are close to the background levels, it might be up to the authority how they decide. So it's not clearly, it's not definitely clear if your active ingredient might be registered or not. That's the reason I would like to introduce the concept of so-called adverse outcome pathways. The background of the adverse outcome pathways is the linkage between the two main anchor points, the molecular initiating event and the adverse outcome. It's at the level of biological organization, and the goal is to provide a framework to describe so-called key events. It's extremely important for risk assessment and regulatory applications. The information can be derived from in vitro, in vivo, or also computational systems, and is an analytical construct that describes a sequential chain at your adverse outcome, and it's again a central element of a toxicological knowledge framework. And how does this look like? So just again the background, you have a toxicant, then you will show the molecular initiating event, which might be an interaction with cell constituents. You will show the cellular response, for example, gene activation, protein production, or also altered signaling. You will have then to show the organ response, which means altered physiology, disrupted homeostasis, or an altered tissue morphology. And at the end stands the organism response, which means either lethality, impaired development, or even impaired reproduction. And it's called the toxicity pathway, the mode of action pathway, and if you can show all elements of that, then you have fulfilled the so-called adverse outcome pathway. And so here I will give you an example from my company. So we did have an active ingredient. I will not call the name, but it can be found here in this publication. It's a chemical out of the carboxamide class of chemicals. It's an inhibitor of succinyl hydrogenase, and it's a fungicide. And in this example, we had to show the so-called molecular initiating event, the interaction with the cell constituents. In this case, it was the CAR-PXR activation. And the CAR-PXR, I think all of you know, they belong to the so-called hepatic cytochrome P450 enzyme inducers, and a large number of non-genotoxic enzyme inducers have been shown to induce liver tumors in rats and or mice. And most hepatic enzymes are induced by receptor-mediated mechanisms, and some examples for those receptors are, for example, the AHR, it belongs to the CYP1A, the PXR, the CAR, or also the PPR alpha. And also other receptors are involved in regulation of hepatic enzymes. And there's also considerable crosstalk between those receptors, for example, between CAR and PXR. And here, in our case, we thought that the CAR-PXR axis might be the relevant mode of action, and the CAR belongs to a member of the nuclear receptor superfamily, and it's primarily expressed in the liver, and it interacts as target genes as an RXR heterodimer, and the CAR receptor has remarkable features like it's constitutively active, it exhibits usually high sequence diversity among species. Oh, sorry for that, the wrong one. this one. And it activates both by direct ligands and also indirect activators. And the CAR receptor regulates hepatic genes involved in all phases of biotransformation. The physiological regulator, it's involved in the lipid homeostasis, in bile acid and cholesterol disposition, and also in gluconeogenesis. And it mediates the rodent hepatocarcinogenesis to certain non-genotoxic chemicals, including phenobarbital. As indirect activators are known, as I said, phenobarbital and also chlorinated insecticides and PCBs. The agonists might be, for example, CITCO. You have also some inverse agonists, and the target genes for CAR coming from the cytochrome P450 family are different ones. And very often phenobarbital is used as a model substance because it's not genotoxic. It's widely used in humans. It's a known tumor promoter in rats and mice. And chronic administration of phenobarbital results in altered hepatic foci and liver tumors more in mouse than in rat. And the proposed mode of action for phenobarbital-induced rodent liver tumor formation is that you have the so-called key event, you have the CAR activation, you have then the altered gene expression specific to CAR, you will see a cell proliferation, a clonal expansion leading to altered foci, and at the end, liver adenomas and carcinomas. So what we had to do as a next step, we had to show that our active ingredient will induce enzyme induction and cell proliferation, and we did that. And the enzyme induction was measured during certain enzyme induction studies, and the target organ is most likely the liver, but the target organ might also be the thyroid gland. As you know, if you have increased liver enzyme induction, the thyroid gland might also be affected as a second target organ. Then there's also given the method how you can measure the CAR expression and the respective nuclear receptor pathway, and also which CYPs are then involved. So we did this with our compound, and overall for the cytochrome P450, we could show that we have a tremendous increase in the liver enzyme activity. It was a dose-related increase in hepatic cytochrome P450 in both sexes. It was reversible at 3,000 dose by itself. So it was reversible at 3,000 ppm, and the treatment was over 14 days, and you can see it very clearly that you have in all treated dose groups 250, 1,500 and 3,000 ppm. You could see this liver enzyme induction. And then going to the specific tests, so we measured EROD, PROD, and BROD, which are indicative for current PXR. And you could see a dose-related increase in PROD and BROD, and only a marginal increase in EROD, which was seen here. And it was again reversible at 3,000 ppm. So we did the same for the mouse, because we had the tumors in both species, and we did perform the enzyme induction studies not only first in the wild type mice, and the standard model we have is the C57 black mice. So you can see again, you have here these relevant pathways, the PROD and PROD method, which is indicative for CAR PXR activation, and as well in the treated male and also in the treated female, you could see a high increase in the respective enzymes, and especially the CYP2B and CYP3A were increased. So this was again another hint for a CAR-mediated mechanism. We did the same experiment also with so-called knockout. CAR peaks are knockout mice in parallel to the wild-type mice, and we did also with the positive compound phenobarbital, and so you can see very well that for the phenobarbital positive control, you can have this tremendous increase in period activity, which is not seen any longer in the so-called knockout mice. So this is indicative that the knockout mice model really, the mouse is doing that what it should do, so there's no activation of the respective enzymes. And the test substance clearly induced then again a CYP2B activity and also a concomitant mRNA and protein increase in wild type, but not in the knockout mice. Regarding clinical chemistry, we could also see the liver parameters which were affected and which might be indicative for liver enzyme induction. So in the red it was the gamma GT and the total protein. It's very responsive here. You have to stay away from the table. So a clear increase in gamma GT total protein and cholesterol in the red and a decrease in PT. And in the mouse, you could see the increase in ALT and ALP, and this is very often seen with liver enzyme induction that the mouse will eventually decrease in total protein, albumin, triglycerides, and cholesterol. So to see then in the next step the answer or the reaction on the cell proliferation level. S-phase response studies were performed. We did perform them in rat and mice. There were BRDU mini pumps were implanted, and we always have the concept to do different time points, and then in the second study different dose levels. So this is important to know in the first step at which time point your rat model is highly responsive. This might be different between the active ingredients. Sometimes you see the cell proliferation peak after 7 days, sometimes after 14 days, but less likely only after 90 days. And if we have then identified the right time point, we will set up a second study with different dose levels, normally at the dose levels at which the CAR study was run. Assessment will be done by light microscopy, H&E, the immunohistochemistry will be performed, and then also the cell counting will be done on digital slides. And the same was also done with the mouse in the wild type, and again in the CAR PXR knockout mice. So what you can see here, this is a nice picture of the cell response regarding the cell proliferation. On the left-hand side, there's a control mate. You can see some single brown nuclear hepatocytes, which is indicative for a positive sign. And here in the treated male, you can see a lot of those labeled hepatocytes, which is a clear sign of increased cell proliferation. And again, here you can see the treated animals after 7 days. On the right-hand side, I put you the pictures from the phenobarbital positive control, and on the left-hand side you have the active ingredient. So we have the H&E stain from the H&E stain, and then BRDU stain, and here the phenobarbital positive control. You can see in the H&E stain a centrilocular hypertrophy and a high labeling index after 7 days compared with the positive control. And you can see after 28 days you have this centrilocular hypertrophy, but a less lower labeling index. You can see only the blue hepatocytes, but not any longer any red dots. And also for the phenobarbital, the labeling index went down. And that's what I meant before. You have to look exactly at which day you have your peak of cell proliferation, that you can really hit the right time point. And after 3 months of exposure, there was more or less comparable between the control and the treated animals, and the rest was only a very low labeling index. This could be shown also here in the table. So we had a transient dose-related increase in the labeling index. It was more pronounced at zone 3, which means centrilocular, and it was reversible at 3000 ppm. You can see it here. So we had the day of treatment here in the x-axis, so 1 day of treatment, 3 days of treatment, 7 days of treatment, and then 14 days, 28 and 91. And we had one dose group with a recovery after 28 days. And you could see that the peak was clearly for the males and the females after 7 days of treatment. And if you investigate this with all zones, the result was comparable. Sometimes it's important to have a different investigation or a different evaluation. Sometimes you have to differentiate in the different zones, because if you measure all zones altogether, then it might be that you see no difference. So we have always the way we do it in both ways. We do the evaluation in all zones, and we do it also separately for the zones. So then you have to show the hypertrophy and the hyperplasia in the tumor. This was seen in our study from very early on. So we could see the hypertrophy and the hyperplasia already in the 28-day study and also the 90-day study. And then at the end, in the long-term study, in the CAC study, we found these liver tumors. And here you can see an overall picture what was seen. So for the liver, so first you have seen the weight, the hypertrophy, and the tumors, and these are the results from the long-term study. So we could see clearly with an increasing dose that we had a clear dose-dependent increase in the organ weight of the liver for males and for females. We had a clear cut-off also for the hypertrophy, and especially in the high dose males and females, tumors, adenoma, and liver carcinomas were seen. And I think you all know how this looks like. So here you have a control male, and this was the picture we could find in the treated animals with centrilocular hypertrophy in a high-dose male. And then in the CAC study, eosinophilic foci, basophilic foci, and clear cell foci were found to a higher extent compared to the control. And I can tell you that we had a intensive discussion over the last months within the pathology community regarding recording foci and also tiny foci in CAC studies, and I can tell you my personal opinion. I think it's very, very important to really to see every foci and to count every foci and to assess every foci in a CAC study, because it might be really relevant, and it's not worth to skip the small ones. You have to take them all, and you have to be clear then afterwards in your report, but you should not say, oh, it's only a small foci, I don't have to take that. You should take them all. The hepatocellular adenomas, they looked like this, with a clear criteria given by Gaurani, and then we could see also the hepatocellular carcinomas. So summarizing this example, we could see in the chronic study a clear increase, dose-dependent increase for the tumors, for the liver weight, and also for the hypertrophy. We could see a clear increase in enzyme induction, which was also dose-dependent, and also for the cell proliferation, there was a clear increase and combined with liver weight increase, which was reversible. And also the cell proliferation was increased, but only at day 7. So some of the animals died at the end. So it might come to the lethality. And what I would like to mention again is it's really important that you have to show the mode of action, because otherwise, what I showed you in the slides before, if you have not shown a clear mode of action, and if you cannot show that your organ or that your tumor onset has no human relevance, there's no chance for register any compound, any pesticide compound in Europe. We saw in this study also thyroid gland carcinogenesis, and I think you also all know that the liver enzyme induction might lead to tumors in the thyroid gland via a well-known mechanism. So you have the increased activity of certain enzymes, and also the glucuronidation of T4 is going up. You have an increased biliary excretion of T4 glucuronate, the serum T4 drops. You have an increase in TSH, you have the follicular cell proliferation, the hypertrophy, hyperplasia, and at the end you will see in the long-term study the tumor in the thyroid gland. And some slides later I will show you why it's so important to know, especially regarding your endocrine organs, what's going on, because the assessment of endocrine disruptors in Europe is also not any longer risk-based, it's hazard-based. And if you have any finding in your endocrine system which cannot be explained very clearly, then this will a cut-off criteria for registration in Europe. And what I said already before, we could also show or see that we have an increased incidence of adenoma and carcinoma, especially in males, and this was also seen in the additional thyroid hormone study, that the T4 was decreased and the TSH was increased. I would like to show you another example, a just recent example, where we saw after the 2-year study in rat and mice an increased incidence of liver and pancreas tumors in the rat study. It was an unknown mechanism, but based on the knowledge we had, the hypothesis was there for a PPR related mechanism. And as I said before, if you have the idea that it might be a certain mechanism which is not relevant to humans, then you have to show this really very clearly. So again, we did perform liver enzyme induction studies, including additional parameters like proteomics and transcriptomics. We did perform again S-phase and cell proliferation studies, and in addition in vitro and in vivo mechanistic targeted short-term studies to show these mode of action. And you are now already a little bit familiar with this adverse outcome pathway concept. And for the liver, we thought at the beginning we will have a PPR alpha agonism. This would be called the molecular initiated event. And we could see a specific pattern of enzyme induction, and related to this molecular initiating event, we had also specific change in fatty acid metabolism. We could see the hepatocyte proliferation was going up. We had also this shown in the cell proliferation study, and we could clearly identify a threshold. Then we saw these altered hepatic foci, and at the end we had the liver tumors in rats and mice, the hepatocellular carcinoma, which were seen in rats in both sexes, but in mice only in the males. And related to the key event 2 and 3, we saw this liver weight increase and also the hepatocellular hypertrophy. And the species differences can be identified or demonstrated at any step of an AOP. And we had to perform the same for the pancreas. We had to show for all of those key events that's really true, that's really there. So we did a lot of additional investigations and studies to show that the bile flow went down and the bile acid concentration was different, so really indicating a PPR alpha mechanism. We could find pH changes in the bile, and also different composition of bile acids, as well as in the plasma. and we had also to show that there were changes in the pancreas for so-called monitor peptides, CCK, being and also secrete. We had to perform the cell proliferation study also for the pancreas. We did here the T67 stain, and again, together with the histopathological changes in the pancreatic acinar cells, we could identify the threshold, and this was really at the end of the CAC study for us also a surprise to see those pancreas acinar cell tumors in rats only in males and females. And when you see something like that, then you go back and then you have to do all those investigations in addition, that you can explain your mode of action, that you can show that you have no human relevance, and that there's a chance that your compound will be registered in Europe. So as I said, you have to assess the non-human relevance. If you see at the end something what you do not expect, first you have to do a literature search with evaluation and application to the available animal and mechanistic data. There will be a very high regulatory acceptance that liver tumors, which are secondary to PPR alpha pathway, it's not relevant for humans because the PPR alpha is differently expressed in rodents in contrast to humans. So signaling pathways are different, and the pancreas acinar cell tumors are very rat specific. Those are not seen in mice and humans. And there's also no evidence for an increased tumor incidence, especially in humans after fibrate exposure. There are a lot of pharmaceuticals out which react or which show in the rat model the PPR alpha activation, but there is no increase in tumors in humans. But as I said, you have to show all those events and key events to really postulate those mechanisms and your mode of action. So overall, you have to establish that the compound is not genotoxic. You have to identify the properties of your compound in order to postulate the specific mode of action. You have to exclude alternative mode of actions. You have to compare your effects on putative key events at carcinogenic and non-carcinogenic dose levels. You have to confirm the mode of action with nuclear receptors, for example, in knockout animals or other specific tests. And the histopathology is very important from the chronic studies for increases in incidence of altered hepatic foci in tumors. And you have to obtain data on species differences to establish the non-human relevance, and this is really extremely important. So there are some tumors which are considered not being of human relevance, for example kidney tumors, if they are, for example, associated with alpha-2 globulin nephropathy, certain pheochromocytomas, light cell adenomas, urinary bladder tumors, forestomach tumors, certain thyroid tumors, and also liver tumors. But as I said before, and I cannot say it often enough, you have to show this mode of action. You cannot just postulate and you think that it might be, but you have to prove. And this brings me to my second important point. The endocrine disruptor legislation in Europe is very complex and, let me say complex. So it's different to pharmaceutical products where you can very often can handle the threshold, or you can say, okay, it's a benefit or it's not a benefit, but you have to know that if a patient takes this and this compound, then you maybe will face this and this event. But this is not acceptable for any chemical or for any dual plant protection product, and therefore there is really a very strict regulation. And in several years there were set up several regulations and also guidance documents, and you can follow those regulations and guidance documents to set up and to identify if your compound has any aspect of an endocrine disruptor, yes or no. And it's also, again, very important to follow those documents. For example, the guidance document 150 on the test guidelines for evaluating chemicals for endocrine disruption. It's written there in the 1107, and I told you already before, this is relevant for the plant protection products, and there's not only something written regarding carcinogenicity, but also the endocrine activity, that an active substance shall only be approved when it's not considered to have any endocrine disrupting properties that may cause adverse effects in humans. So if you have any hint, any concern that you have an endocrine disrupting property, then again the plant protection product pesticide cannot be registered. And there's another legal background regulation coming out in 2018, and this describes again exactly, so if a chemical having endocrine disrupting properties that cause adverse effects in humans, and then it's written down that meets all of the following criteria. So you have to show that adverse effect in an intact organism or its progeny, it has an endocrine mode of action, or the adverse effect is a consequence of the endocrine mode of action. Then, if this is true, then the compound cannot be registered. So, to use specific scientific criteria, all three elements of criteria need to be fulfilled. So the first is, do we see an adverse effect in an intact organism? It's definitely and clear an endocrine mode of action, and the adverse effect which is seen is a consequence of an endocrine mode of action. So then a full weight of evidence approach is proposed, and you can take into account all available data, the positive as well as the negative results. And for example, considering the concept of limit dose and maximally recommended doses, then you can use also those weight of evidence approach, and based on the biological plausibility and adverse effects that are non-specific, secondary consequences of other toxic effects shall not be considered. I will skip this here. So in the slide before, this guidance document was shown, which was published by ECHA and EFSA in 2018. And this guidance document addresses the effects related to the estrogen, androgen, thyroid, and steroidogenesis pathway, the so-called EATS. And it distinguishes between the EATS-mediated parameters and the sensitive to but not diagnostic of so-called EATS-mediated parameters. It defines exactly the criteria when the so-called parameters are considered sufficiently investigated, so there are clear guidance and guidelines what you have to investigate and with which method you have to investigate. It defines how to comprehensively study endocrine activity, and it contains, especially because the thyroid gland is very often affected, it contains an appendix in which the assessment of the thyroid effects are described. So the assessment strategy, which is given there, is based on the three conditions: the adversity, the endocrine activity, and the biological plausible link between those two. So you have to gather all relevant information, you have to assess the evidence, you have to perform an initial analysis of the evidence, you have to perform again the mode of action analysis, and then you can conclude on the so-called ED criteria. The ED criteria are met, which means that you have endocrine disruptor. The ED criteria are not met, or further data are needed. And in this guidance document, a lot of those schedules are given, and you can follow those, what you have to do in your next step. So, for example, the mammalian in vivo parameters are given also there. You have different levels, level 2, 3, 4, and 5. And for example, in vivo mechanistic studies, you can assess the hormone levels, the TSH, T4, and the hormones dealing with estrogenic and androgenic hormones. The so-called EATS-mediated parameters, which will be taken in level 4 and 5 studies. For example, in-life parameters like age, vaginal opening and preputial separation, the östrocyclicity, the nipple development, and vaginal smears. You have to assess the organ weight from the sex organs and also the accessory sex organs, the thyroid gland and the liver. You have to perform the histopathology of those in addition to the thyroid gland, and you have to perform the sperm morphology and the numbers of them. And then other weights and histopathology is sensitive, but the diagnostic of the EATS, these are the adrenal gland, the brain, pituitary gland. And in the OECD guidance, also the studies are given you have to perform. So, for example, the in vitro mechanistic studies are so-called level 2 studies. These are more or less in vitro studies. Then you have the level 3 studies, the heterotrophic and the Hirschberger. The level 4 studies, the repeated dose, for example, or the 414, and also the developmental neurotox study. And then at the end, the level 5 studies to investigate the in vivo adversity of ED-relevant effects is the extended one-chain study, the 443, and also the two-generation study. And if you have at any time point the impression, the assumption that there might be an endocrine effect, then this triggers automatically the studies on the next higher level. So for the assessment of the EAS, which means estrogenic, androgenic, or esteroidogenesis, you have those level 2 studies, and if they are negative, you have the level 3 studies, and if they are all negative, you have no ED activity, and the ED criteria are not met. But if you have the level 2 studies, and if it's negative, you have to go to the level 3, and if one of those is positive, then you have directly go to the level 5 studies. And you know this takes time, and you have to know that this really takes time if you have already in one lower tier study a positive effect. And the assessment of the thyroid, the assessment of the thyroid possibility of endocrine disruption, you will have to perform first mechanistic in vitro studies as well as in vivo studies, and sometimes also comparative in vitro studies. And very often you will run the mechanistic in level 5 studies directly in parallel, especially if the thyroid hormone effects in offspring is confirmed. And if you have any effect on the thyroid level, then you will jump directly to the level 5 study, especially the 443, and then again with the DNT cohort, because the regulatory authority will see that there is no impact on brain development. Or you can perform alternatively also sorry for that. You can perform directly a so-called DNT study, which is described in the test guideline 426. But you see, if you have any hint of a thyroid disrupting mechanism, you have to perform a lot of animal studies. So coming to the end, the conclusion for the cancerogenicity assessment, we do have this kind of classification in Europe with category 1A, 1B, which is a cut-off criterion for pesticide active ingredients. Pesticide active ingredients need to undergo a long-term and carcinogenicity testing. I do not do anything. In rest animals, and you have to test up to doses showing toxic effects. So the observation of increased tumor incidences compared to concurrent and background control levels triggers classification and labeling discussion at the ECHA-RAC. And you have to show substance-specific mode of action and the non-human relevance information. This is very crucial, and these are elements considered by the ECHA-RAC, by the Risk Assessment Committee, when deciding on carcinogenicity category. So this means you have to provide those informations. In order to investigate the mode of action for tumor occurrence, specific in vivo and or in vitro studies are required, usually following, as I showed you, the adverse outcome pathway. And I showed you also some mechanisms for rodent tumor formation is agreed to be of non-human relevance, and the strength of the presented data is assessed then in the ECHA-RAC. So the conclusion for the ED assessment, sorry for that. The conclusion for the ED assessment, there's a very complex legal background and assessment in Europe. The classification and labeling guidance was updated in November 2024 by ECHA to introduce endocrine disrupting chemicals, because this was not included before. The guidance explicitly classifies endocrine disruptors as a health hazard, and if you have any properties of endocrine disruption, this will be a cut-off criteria in Europe. There is any longer any risk assessment on ED. So the CAT1 substances are known or presumed endocrine disruptors to human health, and CAT2 substances are suspected for endocrine disruptors, and it's still under discussion how they will handle those CAT2 substances. The guidance also includes information on endocrine disruption not occurring via the ATS modes of action, as well as the role of adverse outcome pathways in the mode of action analysis. And as I said several times, the EATS parameters in EU, you will have this hazard assessment, not any longer the risk assessment, whereas you have in other countries, North America, for example, and also Japan, you still have the risk assessment. So, coming to the end, many thanks for your attention, and many thanks for the organization to invite me. Thank you.
Thank you, Dr. Sylvia, for a wonderful presentation. May I request Dr. Vijaya Sathi to hand over the mentor to Dr. Brewers as a token of appreciation from Stpi. We are not going to have a question now. We'll start with the next lecture, and we'll keep it reserved for panel discussion. Thank you. Next talk is from Dr. Rene Hoekneel. Dr. Rene Hoekneel is the Director of Pathology at Amgen. She earned her veterinary degree from University of Illinois. Went to NIH postdoctoral fellowship in comparative medicine and pathology at University of Washington. After obtaining ACVP board certification, she continued as a faculty member and pathologist at Washington National Primate Research Center until 2010. She trained in toxicology pathology at the Dow Company while supporting registration of chemicals following REACH regulations and EPS endocrine disruptor screening program. In addition to her current role at Amgen, Dr. Hoekneel has worked as Eisai Company's company supporting IND submission for oncology, neurology, and global health programs. Dr. Hussain is active within Stpi, serving as a past chair of Toxicological Pathology Forum and the Scientific Regulatory Policy Committees. She has authored over 25 peer-reviewed publications, multiple book chapters, and Stpi webinars. She currently serves as an associate editor for Toxicological Pathology, sits on HESI Drug Cell Committee on Targeted Protein Degraders, and is an active member of VICT3R Consortia. Thank you, Dr. Hussain, for accepting the invitation to present at the Stpi event, and over to you.
Thank you, Satish, for that kind introduction. And I wanted to thank the Stpi organizing committee for choosing this interesting topic for our symposium, as well as for your invitation for me to be here. I find it to be both a personal honor and privilege to speak with you today. I'd like to take a step back from what we have been talking about, at least in our first two discussions, what adversity is and perhaps what isn't adverse, and really focus on why adversity matters. Why are we considering adversity as an important topic, and how we effectively communicate it. I was speaking this morning with Sunish, who you'll hear from after lunch, and we were discussing why beginning with the end in mind is really important, and that's what I hope to communicate today. The way our end users take the data and what we can do on the forefront to maybe help or understand what they need that data for. So I'm going to start with a little bit of toxicology and talk about why effectively communicating adversity matters. As Dr. Ramachandra spoke on, it's important to clearly communicate adversity in our pathology reports and further discuss the NOEL, if possible, in our overall study reports. According to ICH-M3 guidance, adversity itself links the findings at the dose level to our first-in-human clinical trial starting dose. I'm going to try to explain this through a fictitious example of a dog study where we have 3 dose levels. Wow. I think it's moving. Perfect, thank you. We have 3 dose levels, 1, 10, and 100. Considering our pathology findings, we diagnosed adversity at 100 mg/kg, so that would make 10 our NOAEL. And if we look to the guidance for industry on how we estimate a maximum safe starting dose, we get a really nice table that divides by species a milligram per meter squared approach to finding a human equivalent dose for our HNSTD or NOEL or any of the dose levels. In this case, our dog conversion is a 0.54 mg when multiplied by the NOEL. Really defines what your human equivalence dose would be. So we then take an appropriate safety factor and divide that 5.4 by the default, in this case, let's say 10. We might have reasons to increase our default safety factor. Let's just say this, though, is a standard small molecule. So after these calculations and some mathematical gymnastics, we have a 0.54 milligram per kilogram dose level as your safe first-in-human starting dose. When we move into oncology, our guidance is from ICH-S9, And this document is really tailored to be able to effectively treat cancer patients faster. So it's leaner, and it allows us to get into the clinic at a significantly higher dose, because ethically it's not appropriate to treat a terminal patient or somebody with severe life-threatening disease with a dosage that wouldn't necessarily, or even theoretically, provide any sort of clinical benefit. So the ICH-S9 guidance tells us that a NOEL is not essential to support clinical use, and that the starting dose is based on one of two factors: the STD10, or the severely toxic dose occurring in 10% of our rodents, or the HNSTD, 1/6 of the dose that is not severely toxic in our large animal species. I'm going to refer to these two collectively as HNSTD moving forward. So we choose our most relevant species and use that calculation. In this theoretical example, of course, it's a standard small molecule in dogs. We can use this approach, but if you're using an immune agonist, you might have to use a MABEL approach, which is a minimally active biological effect level, or a pharmacologically PAD, pharmacologically active dose calculation. But here, we're going to assume we can just go with our standard approach. So our theoretical study, 1, 10, and 100, again, we know the NOEL, we know the HNSTD, but we don't know if that dose level is actually the highest toxic dose level. So we have to understand where lethality occurs, or where something would be considered severely toxic. And in this example, let's just say our dose range finding study at 300 did result in lethality, so we know that 100 now is our HNSTD. So we do the calculations, and we're able to say that the NOEL, again, doesn't matter here, but you take your 100 now, you multiply it by your conversion factor of 0.54, 1/6 of this as an human equivalent dose becomes 9. So all that just says that this location. So oncology is different in the dose levels, but it's also different in the intent of why we're doing that IND-enabling study. For a standard molecule for ICH-M3 guidance, we are performing that study to understand the NOEL. We're safely trying to enter human healthy volunteers. But in the oncology indication for ICH-S9, we need to understand the severely toxic dose. And in that case, the study is designed traditionally with higher dose levels, and we may not achieve that NOEL. We might not even want to dose low enough to see it. So we often don't actually achieve the NOEL. 2 years ago, there was a survey from the IQ Consortia that looked at all of the recent studies that were submitted, and they found that 28% of those studies in oncology did not demonstrate a NOEL. The survey itself was designed to try to understand if there was a more effective way to enter into the clinic than using the HNSTD. They had proposed a NOEL-based approach, and they had proposed using a NOEL without the safety factors of 10, for example. And they found that in this survey, they would be successful in 82% of the cases, safely entering the clinic, and they could remove 21 weeks or 5 months from the actual clinical trial duration. So trying to think around how a NOEL could be used in either case, what I wanted to really discuss was a survey that I was able to perform with my colleagues Mariama San, Dan Patrick, and John Werner 2 years ago. In this survey, I spoke with toxicologists and pathologists from 20 pharma and biotech companies across the globe, and I asked 3 critical questions. The first one being, do you typically use a HNSTD or a NOEL when you're reporting anti-cancer pharmaceuticals? If you do use one or the other or a combination, why? is this your preferred approach? And is your preferred approach informed by regulatory interactions? So taking this information, we distilled down 8 reasons that were collectively being communicated across these 20 companies as to why they do what they do for reporting. The first most frequent reason cited for using a NOEL, even in an oncology indication, is that drugs can be repurposed, and they frequently are. So when you are originally registering a compound under ICH-S9, you have, again, that really fast, streamlined package, and when you move into ICH-M3, you have to have a more robust approach. But you can see here 2 examples of compounds in which that was very successful. The top one is a series of compounds that were originally developed for leukemias, and then 5 or 10 years later, they were re-registered under the M3 guidelines for an MS indication. The bottom grouping is a series of compounds that were registered originally for prostate cancer, and then up to 20 years later, re-entered the registration process for a series of different female reproductive health indications. So given that time, 5 to 20 years later, you have an abundance of human data, and that data can help inform your starting doses and your safe entry into the clinic. But when you're creating those non-clinical overview documents for the registration, you need to readdress your first-in-human starting approach, and it needs to be at least referenced to a NOEL. So if you don't have a NOEL in those studies, you would have to assume or create or speak to what it would have been. And you're doing that without the benefit of the original study team, the original pathologist. It can certainly be done and has been, but it would be better to have the data up front. For completeness sake, in addition to having that NOEL data there, you would have to have a carcinogenicity assay. You would also have to have additional repro and developmental work, and you might have to readdress the photo safety package as well as your impurity limits and other metabolites. So it's not a small ask, but it can be done. The second reason to really consider at least addressing adversity in the pathology report and then speaking to the NOEL in your study report is that there's a real evolving regulatory focus as we get better at what we do. So we're now putting compounds on the market in oncology that are very genetically defined. They have these incredible targeted, specific mechanisms of action. And as such, patients are living longer. So the newer oncology drugs have a wider therapeutic indice, and they can facilitate treating patients hopefully into remission, but now they have long-term consequences of severe or chronic toxicity. So the FDA, at least, and more than likely other geographies, is really looking at how we can more safely treat cancer patients. And in the case of something called Project Optimus, where the FDA is mapping the clinical exposures occurring in patients to the exposure of the non-clinical NOEL, and trying to see if there's different ways of dose escalating. This is a somewhat similar but parallel approach to the IQ survey I was talking about before. So the impact to us is that with an increased focus on quality of life, we really can't wave off severe toxicities that are chronic or irreversible. They're just no longer as acceptable, even in an oncology setting. So 2 examples here would be infertility and cardiotoxicity. We need to be really clear in how we communicate adversity so that we can define a NOEL if possible. This is my personal favorite reason why a NOEL might be beneficial. It's really understanding that dose-response curve. So when you have 2 data points, you know a part of the picture. Knowing your HNSTD and your lethal dose gives you an idea of where the toxicity will end up, but we don't understand that critical window as well in the beginning. So if we had a NOEL, sometimes we would see that compounds that look the same really are pretty divergent. If you have a narrow window, here illustrated by the top line, this narrow window between the exposure of the HNSTD and the exposure at the NOEL suggests a really steep toxicity curve, and you would want to enter the clinic carefully, cautiously, and a traditional approach like a 3+3 would be very appropriate. But if you have a larger window or a wider difference in between the exposure at your NOEL and the exposure at a lethal dose, you could consider a more aggressive entrance into the clinic and do something like a model-based continuous reassessment approach, and that would facilitate getting that critical drug to the patient faster at an efficacious dose level. Another reason for really nailing down adversity in our pathology report and trying to communicate a NOEL is that dosing healthy volunteers is becoming a more common practice in many clinical trials for oncology drugs. This is not applicable for all compounds. If you have a cytotoxic small molecule or you have something that would cause myelosuppression or have any DNA reactivity, you don't want to even think about this. But there's a category of small molecules where this could really work. Let's just use kinase inhibitors as an example. In order to even consider dosing a healthy volunteer, you would have to have additional data, such as a calculation of that NOEL, perhaps also bolstered by the pharmacologically active dose and some PK modeling. You need to know that genotoxicity is clean, so that means you would have to front-end those studies, and you would have to have really solid reproductive risk precautions on your study. But if you have these possibilities in place, or if you have this data in place and the possibility to dose healthy volunteers, I wanted to show you 3 examples of how it could be beneficial. The first is microdosing. This can characterize the human PK, the distribution and the target engagement early. So that means that you can de-risk your phase 1 study by understanding the bioavailability very early in the process. I have an example here of a kinase inhibitor in which this was performed successfully. The next, maybe more controversial approach would be actually enrolling healthy volunteers in your single ascending or multiple ascending dose studies. This approach to dosing patients, this approach would prevent you from dosing a patient at a subtherapeutic level, and you could really get to those critical patients faster because this is an open enrollment for healthy volunteers. You would be able to fill it and get through it much quicker than by targeting specific tumor types in specific patients. There's an example here of how that was performed in, again, another kinase inhibitor. And then the final example covers a broad range of studies in which you could enroll healthy volunteers that are slightly later in development, so DDI or drug-drug interaction studies, food effect studies, TQT or cardiovascular safety studies. Sorry. And mass balance. So the data from these studies really needs to be as clean as possible. The endpoints are super sensitive. So by using healthy volunteers, you can strip out the disease confounders, and the number of patients that you have to dose can be significantly reduced because you have a higher power. Another reason why a NOEL can be helpful is that it can help your clinicians specifically to approach dose escalation in the clinical trial and to really define the monitoring of the clinical patients. I have to give the caveat here that I spoke with pathologists and toxicologists, so this is secondhand information. The clinicians themselves didn't participate in the survey, but these pathologists and toxicologists told me what their clinicians asked them for and why. So in this context, the NOEL can add value because patient exposures, when they start to reach the exposure at the NOEL in the most sensitive species, need to be watched more closely. You either have to slow your dose escalation or you have to add additional monitoring in order to safely continue that escalation. So knowing your NOEL really helps to justify those monitoring parameters and any dose modifications that you have to put into protocol amendments. Finally, going back a little bit to the environmental health and safety and chemical risk factor that we just learned about, there are many possibilities to use a NOEL in occupational health and safety, but these are very dependent on your company's approach to how occupational health and safety is determined. So a health-based exposure limit, or HBELs, use both the NOEL and multiple factors that can be added as just defaults. But if you have your NOEL and you're confident with your data, it's possible to get a more accurate PED or AED. And these matter because these are used to understand the residual drug carryover that's allowable in multiple product manufacturing, residual solvents, experimental impurities, extractables and leachables, and importantly in that occupational exposure limit that ultimately is placed on the workers that are helping us produce our products. Some companies go with an abundance of caution and don't use any NOELs in these calculations early on, but others find having the NOEL to be helpful to sort of level set where they are looking to place the PDE. So two final reasons, and these are more broad arching. The first is effective communication, I think, which has been a theme today. We want to be able to, as sponsors, use a NOEL that we define, that we feel like we can support with our data. We want to remove the ambiguity, if possible, when we interpret adversity. Regulators, of course, are going to interpret the data as they should, but if we're helping to sort of guide the conversation, or at least guide the way the interpretation was done, we can perhaps alleviate some of the confusions that we have to address later in our TQs. In the experience of the respondents to the survey, there was a general sense that if a NOEL was defined, even in an oncology setting, there was less RTQs that specifically asked these questions. But the flip side of that, of course, is that if you get a question that asks you, what is your NOEL? It's very appropriate to respond that the study wasn't designed to find a NOEL wasn't achieved, but here's what we think. So if you want to make your life easier later, the concept of giving more data up front can be helpful. Similar to what Lindsay discussed, more data is always better. And that feeds into the cross-data mining approach that many companies are taking. We're living in a world of AI, data, and really a way of surveying vast quantities of study-related data, human patient-related data. And the more holes you can fill, the more accurate your cross-interpretations here are. So those 8 reasons why you might consider using a NOEL aside, I wanted to show you what we as an industry, at least pharma, is doing currently. It's just a snapshot of 20 companies, but basically half of the companies, so 45%, report an HNSTD or STD-10. In combination, an almost equal half report a NOEL, either alone or in combination with that HNSTD. There are 10% of our companies that do not report either in the pathology reports or in the non-clinical studies, and they reserve this conversation for those non-clinical overview documents, taking each study individually as it is. So given this sort of breakdown of the data, we looked at, was there an association of company size or company region, and we didn't find one. But what we did try to understand was maybe, again, why these approaches were used. So why would you just stick with the regulatory defined HNSTD? And I think the reason is simple. It's what the guidance says to do. It's simple. It clearly communicates to regulators what you're looking for, what you're going after. It helps you set that first human starting dose. It's linked to all of the calculations. And importantly, we don't have a NOEL consistently available. So using a different approach can put you into a tight spot sometimes. Non-clinical studies, again, are designed to identify that MTD and not the NOEL. And I'm not trying to suggest that we should design them differently and add extra dose levels to achieve the NOEL, because that would be contrary to all of our understanding of 3 Rs and animal reduction. I'm simply saying that if you have the data, there's a benefit for using it. I wondered, or I asked also, why would you only use the NOEL if you have guidance that says report that HNSTD? And this was performed in companies because there was a desire for consistency across compounds and indications. And again, this is for that repurposing, for the data mining, and just for consistency and communication to study teams. In the actual regulatory documents, that HNSTD is discussed. So why would you not report either, at least in your study reports and your pathology reports? The reason that this is done is really to facilitate that weight of evidence approach across all studies. If you don't make any decisions or don't make any inferences early on, you're able to do so, again, in the non-clinical documents as a collective single approach. So in conclusion, defining adversity and the NOEL, either in the pathology report or in combination of the study report, for anti-cancer pharmaceuticals can be valuable. But there are multiple acceptable approaches to reporting adversity for oncology pharmaceuticals. And as we saw highlighted in green by Gabby, your company needs to align on their approach and stick with it. And there's nothing wrong with any one particular approach. But you might find one that's preferable based on compound-specific development plans or company-specific practices. I'm happy to take any questions, and I wanted to again thank you for this opportunity.
Thank you, Dr. Buchanan. Wonderful lecture again. Very relevant to all of us. Open forum for questions.
Very nice presentation. Thank you. My question is that how much margin of safety is required for the IND filing? You can say in FDA or DCJ, because most of the cases will not, we are seeing in small molecule, will not get much margin of safety.
Oh, are you asking how to define mild versus severe toxicity?
Yes, for IND filing.
That's a great question, and it actually really isn't defined. I can tell you that severe toxicity is very close to lethality, but there are very few definitions out there of what's the difference between adversity and highly severely toxic. It's a great question. I don't have an answer for you, but maybe our panel can address that later this afternoon.
Generally 10 times margin of safety people are talking and discussing and reporting also for the IND filing especially. So what is your opinion on that? If it's less than that, is it the IND filing will be there or not?
I'm sorry, I don't think I understand that part of your question, but I can speak to the two factors that can help inform that severe toxicity, or the differences would really be, is it irreversible and is it monitorable?
Oh, thank you, thank you.
I'm standing in between everybody and lunch.
Thank you, everyone, and we are now breaking for lunch. So during the lunch, we have very limited space standing outside, so take your plate and you can use this hall for having lunch. And during the lunch break also we request you to visit the sponsor booth and please join back within 1 hour. Thank you.